Okay, great. Well, that was wonderful. And we are going to now move to the second part of discussing the clinical trials landscape. We're going to have a wonderful discussion and speaker. So I'm just going to introduce our moderators, Dr. Jisna Paul, and also Karen Cheng that you've already heard from.
Hello, welcome to the next session. I'm Jisna Paul, an adult rheumatologist from Ohio State University. The next session, I would like to welcome Pedro Machado, who's Professor of Rheumatology and Neuromuscular Disease from the University College of London. He'll be giving us an overview of CAR-T therapy and trial implications.
Thank you. Thank you very much. And the testimonies that we've had so far, they've been a fantastic introduction to this forum, and I'll just try to summarize some of those thoughts and also give an overview about CAR T cell therapy as an introduction to the next section. So I'll share my slides, okay. And you should be now seeing my slides in full screen. Immune-mediated muscle diseases, so the idiopathic inflammatory myopathies, they're truly systemic diseases with a lot of potential end organ damage, not only at the skeletal muscle level, but also at the level of the skin, the joints, the heart, the blood vessels, the lungs, and the GI tract. So there's a lot of potential damage and potential life-threatening complications, a lot of potential for disability and loss of quality of life. And although we have a good range of drugs that we currently use to treat our patients, we also know that these drugs are not always effective, and they do not work in a significant proportion of patients who sometimes partial respond to these medications or don't respond at all. And therefore, there's a need for additional therapies in the idiopathic inflammatory myopathy spectrum. And for example, in IBM, there's still no effective drug treatment for that patient population. And over the last few years, we've really witnessed a huge expansion in terms of clinical trials in myositis. Even before CAR T cell therapy trials started, we were already being bombarded with multiple other clinical trials, and these included pathways such as targeting type 1 interferon, for example, with JAK inhibitors, toll-like receptor inhibitors, among others, drugs that target co-stimulation of T cells, complement inhibitors, and other types of immunomodulation, such as FcRn inhibitors. And obviously, IVIG was already being used, but there's also several ongoing trials with IVIG. And now, we're already using anti-CD20 antibodies, but then there is the potential for a new target, and that target was CD19. And why CD19? Well, because by targeting CD19, that will allow targeting a wide spectrum of B cells and plasmablasts. And that could potentially lead to better outcomes and a wider depletion of B cells. And that's how CAR T cell therapy came into play. And these are essentially genetically modified T cells, and they're modified using a viral vector. So the viral vector is used to introduce a new antigen receptor on the T cells. And that's why it's called a chimeric antigen receptor. And then these T cells, they gain the ability to identify a new target. Now, if we think about oncology and malignancies, their target is CD19 because around 95% of the B-cell malignancies, they express CD19. But we can then translate that to autoimmune diseases where the tumor are the autoreactive B cells. So that's the principle. Let's look at the autoreactive B cells are the tumor, the B cells producing the antibodies. And that's why also it only makes sense to use this type of approach in diseases that are antibody mediated, where there's a clear role for the antibodies in the pathogenesis of the condition. So if you look at the bottom figure, we already have antibodies against molecules expressed on B cells, such as CD20, and we've now developed new ways of therapeutic B cell depletion. There's another potential therapy that is being used, although that's not the topic of this forum, which is bispecific T cell engagers or BiTEs. And so these are a class of bispecific antibodies, and they can, for example, target CD19 on B cells and CD3 on T cells, and then they bring both these cells together, enabling T cell directed cytotoxic killing of the B cells. However, with CAR expressing T cells, these are designed to target surface molecules on B cells. And CD19 is the most common one, but not the only one. And this makes them as capable of effectively depleting B cells. There's been a lot has happened over the recent months, years, in terms of how these CAR T cells are generated. In general, there's an intracellular domain and an extracellular domain. So the extracellular domain has the antigen binding domain, so that recognizes the target, let's say, and then that's linked to an intracellular signal domain by this INJ domain. And then there have been variations about how this intracellular signaling domain has been constructed. But an important point is that at a certain point in time, it started including a co-stimulatory domain that has increased the efficacy of this type of therapy. And then multiple approaches have been tried by different academics and also by pharmaceutical companies. And in terms of the spectrum of CAR-based treatment approaches, this can vary in terms of the transduction method. So that's point A, the treatment procedure type. So that's point B. The cell resources of the product, point C, and then there's new methods also for the target cell killing. Now, regarding the various transduction methods that are used to introduce the genetic information of the CAR into activated cells, these have been mainly viral vectors. But there are some new approaches that are being developed, like lipid nanoparticles, which can deliver mRNA to the T cells. And also these lipid nanoparticles can be used to deliver gene edited by CRISP. So these are the potential approaches for transduction methods, although obviously the viral approach is the most common one and the one that is most commonly used currently, often with the lentovirus, although retrovirus has also been used by some companies. Now, in terms of the type of procedure, the one that is more often used and the one we know more about is the autologous approach, which is based on the cells of the individual that are extracted from the individual. That's the leukapheresis process. But there's other process being developed, namely the use of allogeneic CAR T cell therapy, where T cells from healthy donors of cord blood or inducible pluripotent stem cells are used. And these are often called off-the-shelf cells because they could potentially be readily available for immediate use. And more recently, there's also some approaches to try to do this in vivo. But I think today we'll focus on the autologous approach, which is the one that we know more about and the one that is more commonly used. And although CAR T cells are the most commonly used CAR-based strategies, it's important also to bear in mind that other cell sources are also under investigation, including gamma T cells and natural killer cells, as shown here at and in the left bottom corner of the figure. Then there are several new methods, and these are all investigational. I will not spend a lot of time on those, but there's a lot of research being done, and these are often called next generation CARs, including armored CARs, and you've got a few names here. But essentially, where the CAR T cell approach is often coupled with a second approach, like targeting certain cytokines or other types of cells, and they've been given various names depending on the approach. Okay, see, this slide illustrates the cell therapy landscape for autoimmune disease, and it's just impressive to see how the field has evolved. And this is not an exhaustive list. There are probably more, and this is probably already outdated. But the indications now include not only conditions like lupus, systemic sclerosis, idiopathic inflammatory myopathy, Sjogren, but in many other specialties, namely neurology with multiple sclerosis, myasthenia gravis, autoimmune encephalitis, etc., etc. So the field is expanding enormously. Obviously, these are mainly phase 1 and phase 2 studies or preclinical studies, but eventually we'll probably see also some late phase studies here. This is the limited list of clinical trials in idiopathic inflammatory myopathies, so CAR T cell trials. And although there are significant and important difference between all of them, I guess if we had to say what's the common denominator in terms of the inclusion criteria and the population being targeted, these are antibody positive patients, which is kind of obviously given the mechanism of action, with severe organ manifestations, and this could be muscle, skin, lung, or a combination of all of them, and disease that has been refractory to multiple treatments. And again, the number of treatments vary depending on the clinical trial. And I think it's important to acknowledge that this story probably started here with the group from Germany, and they recently published their case series of 15 patients that they've treated with CAR T cell therapy, including 3 patients with myositis. And again, in this study, and this is an academic study, they included patients with treatment refractory disease that had severe and progressive disease course, namely in terms of the myositis patients. They all had that active myositis and also evidence of interstitial lung disease, so both muscle and lung involvement, and they had been resistant to multiple treatments. And these are the 3 patients that they treated in Erlangen in Germany, and you can see here that there was lung and muscle involvement, and that they had been treated with multiple drugs. All these patients had been treated with at least 4 or 5 drugs, and some of them even like 6 or 7 drugs, so resistant to multiple treatments. And you've heard about the outcomes. I won't go into a lot of detail about this. The outcomes that were reported were very good, with improvement of strength, function, and reduction of CK levels. So in summary, very promising data. but also significant concerns about the future, which patients should be eligible for this type of treatment in terms of medium long-term outcomes. What is the safety profile of this therapeutic approach? Having said that, we do have important information from hematological malignancies. What we don't know is to what extent this evidence can be translated to autoimmune diseases, because obviously these are very, very, very different conditions. But it's important to bear in mind that more than 34,000 patients have been treated worldwide with hematological malignancies. And for example, in terms of T-cell transformation, only rare cases have been observed among these 34,000 patients. So there's a lot of uncertainty, and that's exactly the reason why this forum was developed. And a few things to consider, and many of these things have been already mentioned today, is choosing the right disease for this type of treatment, selecting the right patient. And to be honest, it's likely that the right patient will vary depending on the development stage of the drug. I think the patients that we will be treating in 2-3 years' time will be probably quite different from the patients that we will be treating now. The choice of target, is it CD19, is the B cell activation receptor, is it what's the role for lymphodepletion, what's the best treatment strategy for lymphodepletion, how should we monitor these patients following CAR T-cell therapy, or what should we do in terms of concomitant treatments before, during, and after CAR T-cell therapy. How should we manage flares and relapse after CAR T-cell therapy? Should there be a role for another CAR T-cell infusion, if that's the case, for example? And of course, managing toxicities, it's another area of concern, although from what we know so far in terms of toxicity or short-term toxicity, the safety profile seems to be better compared to hematological malignancy. So a few of the items that I'm sure will be extensively discussed today. And thank you.
Thank you very much, Pedro. Hi, everyone. My name is Cheng. I'm a patient living with myositis. Next up, we have Susan Shenoi, who is a pediatric rheumatologist and clinical director at the Seattle Children's Hospital, and also an associate professor at the University of Washington, as well as Vicki Werth. She's a professor of dermatology from University of Pennsylvania, and both of them will provide their insights on the relevance of CAR-T in children, especially also in children with skin-predominant diseases. Vicki and Susan.
I'm Susan Shenoi. I'm a professor in pediatric rheumatology at Seattle Children's Hospital and Research Center, and I also help run the Seattle CureJM Center of Excellence. I'd like to thank the organizing committee for inviting me to record this video on my perspectives in CAR T-cell for juvenile myositis. Juvenile myositis is a rare orphan disease, and pediatric patients tend to present with more severe vasculopathy, including skin ulcers, as well as they have more severe calcinosis. As many of us know, there currently are no FDA-approved treatments for the management of juvenile myositis, and the pediatric rheumatology community is facing a severe workforce shortage. This leads to delays in access and care for our patients and families with juvenile myositis, which puts an undue burden on them. We as a community in pediatrics are extremely excited about the possibility of CAR T-cells for juvenile myositis. There are a few clinical trials that are enrolling pediatric patients for CAR T-cell therapy, and there is actually one published case report for autologous CD19 CAR T-cell therapy in juvenile myositis. This report is a singular case report presented by the Italian group that was recently published. And I'd like to talk about this patient. This was a 12-year-old child with refractory juvenile dermatomyositis. He had ulcerative skin disease and severe myositis, as well as extensive calcinosis. He had failed therapy to chronic long-term steroids, including oral and IV steroids. He had complications of steroid therapy, including a compression fracture. He had failed prior MMF, hydroxychloroquine, as well as IVIG. He'd received 2 rounds of pheresis and 2 courses of rituximab, in addition to 6 months of cyclophosphamide. Autologous CD19 CAR T-cell was given as indicated by the vertical dashed lines here. And as you can see from the before and after pictures, after he received this therapy, he had a dramatic clinical response with resolution of his skin as well as muscle features and significantly improved calcinosis. Several scores, including his physician global assessment, his CMAS, CAT scores, and the interferon scores, all improved. As is known with these therapies, this patient experienced mild cytokine release syndrome, transient anemia, and neutropenia. However, encouragingly, he is off all medications at 6 months. The authors monitored for B-cell reappearance, which they noted occurred at about 8 weeks. However, despite appearance of B-cells, this patient's clinical remission persisted, which tells us that CD19 CAR T-cells are able to reset that B-cell compartment and eliminate potential autoreactive pathogenic B-cell clones. So this is really encouraging. Even though it's a singular case report in the pediatric field, it's very encouraging and promising. However, as we move forward, there are a few thoughts that we should consider for our pediatric population. We need to be inclusive and mindful of including and enrolling pediatric patients in CAR T-cell therapies systematically worldwide. We as a group need to identify who is the right patient with juvenile myositis to receive CAR T-cell therapy, and when is the right time to give CAR T-cell therapy to our pediatric patients. And last but not least, when we're giving these therapies to pediatric patients in their teens, we really need to be mindful and thoughtful about monitoring for long-term outcomes that are seen with some of these therapies, and be vigilant about learning from what is known through the adult studies. That being said, we at Seattle are very fortunate to have a current trial that is enrolling pediatric patients with lupus for CAR T-cell therapy. And we're hopeful that in the future, we will be able to extend these therapies to other indications in pediatric rheumatology. I'm sorry to miss the conference, but I will wait and watch the recording. Thank you again for inviting me to come share my thoughts.
So I wanted to briefly share a perspective, mostly a dermatology perspective with autoimmune disease related to CAR T cells, bispecifics, and siRNA. I mean, there are many ways to modulate the immune system, and there are many more that are under development. And there are different safety issues with all of them. This is looking at CAR T cells, and as we know, there are many different constructs that are now available and being tested in autoimmune disease. And so in terms of the unmet medical needs, in terms of B-cell depletion, essentially diseases that need deeper depletion of tissue B-cells are a really great target. Diseases where there is a long-lived B-cell making antibodies, such as targeting CD38 or BCMA, and diseases where rituximab helps, where essentially the short-lived plasma cells are making the antibodies that are pathogenic. I've listed some of these here, and some of them I put question marks because we have no evidence at all, but we know that rituximab can work for a number of these different conditions. So this is an example of pemphigus vulgaris, and you can see widespread lesions. You can see the flaccid bully and oral involvement, and also mucous membrane pemphigoid, which can cause blindness. And so there's a lot of unmet medical need, and there's some diseases where rituximab doesn't help that much. And I will say, for instance, that skin predominant dermato is one of them. Cutaneous lupus may be a second one. And it's not so clear with monoclonal gammopathies that can lead to things like scleromyxedema or scleroedema. So it seems clear that targeting CD20 can help remove lots of B cells. And again, in the case of something like pemphigus, we know the antibodies are being made by these CD20 positive cells. And we know that now in the era of CAR Ts, we can really be targeting very specifically antigens that will remove different types of these cells. So again, pemphigus works with rituximab, it gets better. But relapses are frequent as memory B cells escape depletion. There's deeper depletion, which may lead to prolonged remissions. And depletion of tissue-resident B cells is a greater challenge than in the periphery. If it's long-standing, maybe longer-lived plasma cells that aren't depleted with anti-CD20. So you have to start thinking about other ways to target the cells that are making the antibodies. And in terms of autoimmune bullous diseases that are not being looked at, there's lots of them. We're not that great at treating many of them. And so in terms of dermatology, I think, basically there are some diseases that would benefit from this approach. I will say that the bispecifics are interesting, although they've got their own set of issues in terms of side effects, but you may have the advantage of off-the-shelf lower cost treatments in the end with no need for lymphodepletion. And I think that will be really helpful in being able to target a broader population. But they're still going to require monitoring for CRS and ICANS, cytopenias, and infections. So we still have issues here in terms of the side effects. And it's not clear that therapies are under development won't meet much of the need. And by that, I mean non-CAR T cells. We have a lot of therapies in the pipeline that are likely going to make a big difference for many patients and potentially be easier to use or cheaper or accomplish what we want to therapeutically. So the safety profile will need to be established in life-threatening diseases, initially at least, and then we can potentially be looking at other more non-life-threatening or less severe disease. And then the risk-benefit ratio will be different for most derm disease relative to other diseases that are perhaps not skin-related. And right now with the conditioning regimen, including cyclophosphamide, fludarabine, if that changes, I think it'll be easier to think about this more in dermatology population. And severe patients may clearly benefit, and in the future may be cost-effective alternatives. We get more off-the-shelf CAR T cells and bispecifics, which combine T cells and B cells simultaneously in direct killing. So I want to really just conclude in saying that there's certainly a lot of need. Certainly autoimmune blistering diseases is one of them. Connective tissue disease, such as dermato, is another potentially. Technology is rapidly evolving, and as safety and ease of delivery develop, we're likely have applications in autoimmune skin diseases where B cells are important. And so I want to thank you for listening and happy to discuss further.
Thank you. Thank you, Pedro, Susan, and Vicky. At this time, we open the floor for open discussion, and please raise your hand if you have any questions.
Hi, my name is Reza Mears. I'm a rheumatologist in Hamilton in Canada. I think, obviously CAR T cells are very exciting. That's why we're all here. One thing that I think hasn't been discussed as much is what about just targeting, maybe it's not cellular therapy that we need, maybe it is, but what if it's just the target? I haven't seen any trials for CD19. That would be cheaper. There's an off switch. You can stop giving the biologic. There's no chance of this cytokine storm. If someone gets a severe infection, you can stop it. There's no chance of this CAR T-induced T-cell leukemia that you guys have probably read about in New England in the past few months. So I wonder if anyone is familiar with this.
Reza, do you mean CD19 B cell therapy like in epolizumab or?
Yeah, I've not seen that done in our diseases.
Yeah, I've not seen that as well. Good point.
I agree. I think it's approved for NMO, is it correct? Or one of those diseases. I think there's been some talk of it's an excellent point of looking in that space, applying it. I just don't think anyone has done it. I completely agree. So
Yeah, I reached out to a pharmaceutical to propose an investigator-initiated trial about
yeah,
it. And they're like, oh, we're looking into this. And that was the last I heard.
gotta push harder. Okay.
Yeah, exactly. I should.
Yeah, I think it's an excellent point. There's potentially CAR T cell therapy could still have an additional advantage, which is by reaching tissues and areas of the body that the antibodies cannot reach, which has also been a concern with anti-CD20 therapies. So, for example, with CAR T cell therapies, they can cross the blood-brain barrier, for example, and they could reach some areas of lymphoid tissue that is not reached by monoclonal antibodies, essentially. So that's a potential theoretical advantage of CAR T cell therapy. The other thing is that makes CAR T cell therapy more attractive is this possibility of a reset of the immune system, right? So the possibility of a curative treatment as opposed to another treatment that needs to be given chronically and potentially forever. So yeah, so I think it's a very interesting approach, but and we should probably explore that. But there's still advantages or theoretical advantages from CAR T cell therapy that do not exist with an antibody therapy, and I think these are the main two: the possibility of reaching hidden cells in deeper tissues, and the possibility of a reset of the immune system and a curative treatment that you'll not be able to achieve with an antibody.
I mean, I'll say that in pemphigus, we do sometimes get cures, basically because B cells are reset with rituximab. And in lupus, anti-CD38 has been used and then published. So targeting these different cells types have been done with antibodies. I do think there's potential for potentially more patients having a longer cure. But I think even in the lupus world, there have been some mild relapses after CAR Ts. And so we have to learn more, to see how this is going to work.
I agree. I think there is a relapse. I think there's a report even in myositis, and we don't have the long-term follow-up. I think this is the problem. So I'm kind of just waiting to see what's going to happen too. What is the long-term follow-up, like 14 months, 24 months, or I don't know, for myositis at least. I don't know about the other diseases. Yeah. Definitely there's been relapse with lupus patients, correct? If I remember, there's some reports of that.
Yeah, there have. I mean, I think it's been mild relapses and the patients have been really severe. And so they've gotten a good quality of life in between, but you would hope that a therapy like this would be, truly curative and not, so we need to learn how often it's not.
I think Karen put a, oh, that's great.
Oh yeah, sorry, no, you guys were discussing, so because this term of resetting and rebooting and reformatting and whatever, there has been some discussion about this cyclophosphamide doing most of the job already prior to the CAR T, and I'm not sure of any of the trials that I've seen so far that they are actually comparing the effect of this resetting preconditioning.
Yeah, that's also a good point. Although we've been giving cyclophosphamide for many, many years, and we haven't seen anything comparable to what we see with CAR T cell therapy. So personally, I think that's very, very unlikely, because otherwise we would have seen this in the past, and we'd be giving cyclophosphamide in higher dosages and as well, and much more frequently than just the preconditioning required for CAR T cell therapy. So although I think it's a good point, personally, I think it's very unlikely that the cyclophosphamide or the fludarabine are playing at least an important role they've obviously important, and that's essential that they are given, but it's probably for other reasons, and then I don't think they're responsible for that potential reset of the immune system. Otherwise, we would have seen that in the past, and that's not the case.
That's great.
And some of the off-the-shelf products, there's no need for the ablative cyclophosphamide fludarabine regimen before. So that will be interesting to see if they will achieve this reset. And also the thought that some of these off-the-shelf products, they won't last forever. So unlike in hematological malignancies, you don't need to have such a prolonged B-cell depletion. We just need to reset. So that would be all interesting to see whether we can do this with least toxicity.
Great. I think Valerie also has her hand up, so I don't know if I want to give her the floor.
Hi, so thank you so much for organizing this. I was wondering, because we're talking a lot about what we fear and what might or might not happen, but I was wondering if some people in the room are actually part of a trial right now, and what has been their experience in setting up for, because at least for us, we're less excited because it's so hard to like get the infrastructure and the help and the support locally to really participate in any of these. So I was just wondering if people were actually doing trials in the room using CAR T cells.
I think that's a great segue, Valerie, to our next session.